For those of you who don't know me, I'm Ty Gluckman. I'm a cardiologist here in the Providence system in Portland, and I have the distinct pleasure of introducing our next speaker today. I think he holds two distinctions in the sense that we're also stealing him to speak tomorrow, so I'd have you stay over for hearing him at the symposium tomorrow, and I think he's traveled the furthest to Portland for coming out to speak as well. And that's Dr. Manesh Patel. He is currently the assistant professor of medicine at Duke and the John Bush Simpson assistant professor of cardiology. He helps to be the section leader of Duke's peripheral vascular program, the assistant director of their cardiac cath lab, and he also directs their cath lab research program. I think the two areas that highlight him in particular for today and tomorrow is that he's a member of the American College of Cardiology Task Force for Appropriate Use of Cardiovascular Procedures. This will become particularly important for tomorrow's discussion. And he also chairs the AHA Diagnostic Interventional Cath Committee. And it's a real pleasure and honor for me to introduce him today. So thank you.
Well, thanks for such a warm welcome, and hopefully I can go through some things. I'll say that it truly is a pleasure to be here and to talk to you a little bit about what we're, and I think they're getting my slides up, what we did for acute MI systems in North Carolina. And when I say we, I had very little to do with it. As I know Fred was saying, how many of those things that you see get better did you play a role in? I played the role as an interventional cardiologist, as the person at Duke who was a champion, but you're going to see it takes a huge team. And it's some interesting stories about how we did it. I want to share what we did. I know Chris Granger's and others in our systems played larger roles, and we have a lot of the materials that are available and lessons learned, so hopefully we can share those with you all as we go forward, and then we're all still learning. So disclosures, you've heard many of them. There are a whole variety of research and professional roles I play. I don't think many of them will play a role in the conversation. I'll start with Don Berwick, who says one thing is certain, in the era of fragmented care delivery, it should draw to a close. Too many Medicare beneficiaries, like many other patients, have suffered in the hands of wasteful, ineffective, and poorly coordinated systems of care. This will be sort of a theme for me for 2 days. Today I talk about systems of care for race, STEMI. Tomorrow I'm going to talk to you a little bit about appropriate use and where I think it is. A little bit of a sidebar. I think what you've seen here today and what you all are doing is the wonder of the profession of cardiology, interventional cardiology, and all of the things we do. Unfortunately, there's so many things going on in the system right now. There are a lot of news stories and a lot of things where I believe we can improve our care, self-regulate, and make patients do better. I think we have to take the bull by the horns, and you'll hear me say that a few times. So I won't belabor the evidence for reperfusion therapy except to say that at the bottom of the slide, it's 1994. Fibrinolytic therapy at that time was shown to clearly reduce mortality, 1.6 lives lost per hour delay after randomization. So in 1994, we know at least one therapeutic saves lives. And I'd say pretty quickly by 1996 and on, from PAMI and others, people would say ST elevation MI treated with primary PCI was certainly a very valuable system in how we can take care of our patients. This is a slide you've likely seen by many. Bill Gates in 2007 says at the Harvard commencement, where he dropped out of Harvard, so it was kind of probably good for him to get back. Humanity's greatest advances are not in its discoveries, but in how those discoveries are applied. And so in 94, 97, we know that these things help our patients with acute MI. And what you've seen already nicely, in the last 10 years, there's been a reduction in overall mortality from cardiovascular disease. And as interventionalists, sometimes people say it doesn't have to do a lot with angioplasty. Well, in this setting, it might. And this is a place where the systems probably played a role. So I'm going to talk to you guys today about the Race Duke pilot in 2003 and then what we did in the state. And as all good stories, this story starts with kind of a crazy fellow. So this guy, Matt Lofty, came to us from Canada and wanted to set up some systems of care stuff at our hospital. And he was there for 2 years doing research. We were like, okay, what do you want to do? He's like, well, do you guys have a hotline in the CCU? Do you have a phone if the ED doesn't want to talk to all the referring people? Can they just call the CCU and speak to your on-call fellow, say, I have a STEMI, and do you just push a button and start the process? We said, that sounds like a good idea. And so he and Jamie Jollis and Chris Granger and others started putting this in place, and we called it the bat phone. So if you're in the CCU, the bat phone rang. You had to answer the bat phone amongst everything else, unless you were scrubbed with a procedure. And then the bat phone would get kicked to the charge nurse, who would find one of the physicians who could answer this phone. This is step one. I can tell you in the last 6 months, I've spent some time with a Duke computer grad about an app, because we keep trying to activate, and we're activating so many different people. We don't know if everybody's been activated, so we're trying to come up with a now electronic system to get everyone activated. So then the second thing you need is good leadership and money, as you all know. And so this slide is meant to show you what actually happened. So Chris Granger and Jamie Jollis went to Blue Cross Blue Shield. And in their great wisdom, they were willing to support a pilot that was aimed at improving the public health of North Carolina patients having heart attack. We said we'd set up 5 regional centers where primary PCI would happen. We'd hire nurses and coordinators in both the emergency rooms at the places to help with the data collection, help with the process of care. And we would have the hospital support 40% of the cost, and 60% of the cost would come from this grant. But in general, this is how the process started in 2004. And then I'll come back to this publication, but then in 2007, RACE, as the North Carolina proposal, statewide ST Elevation MI publication, was voted, to Chris and Jamie's credit, one of the top 10 advances in the AHA in 2007. So what do we have in North Carolina, and how's it like Oregon? I don't know about Oregon that much, so I'm going to learn from you guys this weekend. But we have 21 primary PCI centers in North Carolina. We have 540 EMS systems. We have 5,240 paramedics, 18,000 EMTs, 118 emergency departments, cardiologists, all of whom think they know the right answer to most clinical syndromes, and it's pretty significant competition. So if you're in the Raleigh-Durham area, I'm at Duke Hospital, but there's Rex, Wake. If you're in Charlotte, there's 2 hospitals across the street that are competing to try to deliver the best care. And then, of course, we do have a little bit of the Blue Ridge Mountains out west. So we have Asheville, North Carolina, with one big practice, but then they have to go over overpasses sometimes for STEMIs, and there's weather, so there's issues about how do you transfer there, and are there landing pads? So we have, and then the coast out here, the beautiful Outer Banks. We get hit by a lot of hurricanes, but if you have a heart attack in the Outer Banks, at the time, you might have to get on a ferry in one of the Outer Bank islands to get to care. So we have large geographic diversity in how we were thinking about taking care of these patients as we think about where they could live in the state and how do they get to care. What's the bell? When you ring the STEMI bell, how do you get places? So I don't know if the puzzle came together that nicely, but the goal was to take that and make it an integrated AMI system. So let's walk through what a STEMI patient could do in your system, in our system, in any system, right? So you can have a STEMI patient that just shows up to a primary PCI center, and I got to tell you, in 2003, that was the majority of ways we got STEMI patients. They would show up either by themselves or by EMS, and they would come to a primary PCI center. But of course, we had a few non-PCI hospitals that would identify these patients, and then they would, of course, get EMS at that center to help. And of course, you've already heard some, and I'll come back to door in, door out times by Tracy and others. But then we started thinking, well, EMS might be able to bypass this, and just imagine the consternation that occurs at some of the hospitals in the state if you'd say you're going to bypass certain hospitals to get to other hospitals. But we had meetings, and we talked about how could we institute ECGs and correct diagnoses so no one was feeling like we were bypassing all of the patients that could be going to hospitals, but we were truly taking ST Elevation MI patients and getting them to the care. And then, of course, you could just have EMS go between these two places. So we wanted to collect time from symptom onset, size of MI, fibrinolytic eligibility, age. We wanted to collect a lot of things, and some of that, of course, changes as you try to practice and do the program. But as we thought about it, here's what we were dealing with. And now this is just fast-forwarding a little bit to say, at the end of the day, ACTION, the registry data you'll be getting as you participate, will tell you some of this. Each quarter, it will be able to tell you, how do you do for patients that are both being transferred in and those that are non-transferred in their door-to-device or door-to-balloon times. And in many ways, when we present to our STEMI meetings, we had to have meetings, we had to think about this. We said, let's break them down into 2 groups. Those that were always coming to our hospital, and so we can improve those patterns, and we did. In fact, if you walk in as a patient to Duke University Hospital up to a year ago, and you're having chest pain, who's the first person you meet? The registration clerk in the ED, who has the least amount of medical education, who tries to get your history and determine if you need an EKG, and if they get it wrong, you get told to go sit down for a little while. So we realized one of our first metrics where we were having patients being evaluated, and we couldn't get that ECG within 10 minutes because we weren't able to get them to the best evaluation. So we went through registration clerk evaluation. We actually stationed a nurse there for pregnant patients, a bunch of other things the ED identified that we could get out of the system right away. So it's sort of like the Disney World Fast Pass. If you said these 4 things, you got the Fast Pass. Sometimes the Fast Pass isn't the best thing to have happen. Sometimes it's beautiful, it's childbirth. Sometimes it's acute MI. Okay, so there are other things that we identified. Of course, Tracy and others, I think, did a nice job in saying in the transfer place, door in, door out seems to play a large role. And this is a very nice, publishable, important paper that says 30 minutes is the goal. And I'm here to say, we continue to strive for this. It may not always be attainable. I mean, door in, door out of 30 minutes means somebody shows up at another ED, they do all the processes and then get the patient back out within 30 minutes, and they've diagnosed STEMI and have done whatever therapy and have contacted the place that it's going to. I'm not saying we don't want to do that. I'm just saying it may be patients that are somewhat selected at times, because if you did have a cardiac arrest at that outside hospital, that's good that you went there. They're going to defibrillate you. They're going to do some things, but it takes a little bit longer. And as you think about STEMI networks, and you're building a STEMI network, recognize stroke, cardiac arrest, thoracic dissection, cold legs. Everything else is going to be important too. And the more you can do this, the more your patients and the more each of your individual hospitals and outcomes will improve. So, here's sort of another way that Fred already showed you that. So from 95 to 2010, I showed you sort of the Lancet paper. And then in here you have primary PCI. And then with a lot of effort, we have a lot of people, however saying we're going to do primary PCI, and look what we've done. Without question, I think a significant change in the mortality of patients who are doing better with cardiovascular disease, at least in part, is because we take care of acute MI better. Of course, that's led to a large population of elderly patients with heart failure, but we have improved their mortality and they've done better, and we're now dealing with the other issues that happen as patients get over the acute MI. But this is staggering. As we hear the news stories, as we take care of our patients, it's always important to remember, as a field in medicine, we're improving the outcomes and reducing the morbidity of our patients at a staggering pace right now. So what levels of organization are you going to have to think about as you guys do it? And I really like the attainable goals. Like for the next year, what can we do? I think this is an important process. So first, at your own sort of shop, in your own house, can you, I'm not saying get silver recommendation, but can you come up with the processes so that you know what you're going to do? Then as a state, you're going to have to decide. You know, Tim Henry, Minnesota, a lot of these people have said, well, we like the hub and spoke, and they've been able to do that. And that may be a reasonable one for Oregon. We, as a larger state, or I guess a similar size state, but a different population across groups, said we're going to do every hospital, every EMS agency, because a lot of our own places wanted autonomy in how they did it. This regional system versus hub and spoke is something you'll think about. Well, you know the guidelines. They say 90 minutes, 120 for first medical contact, especially if you come to a non-presenting, 90 minutes from first medical contact if you get to the primary PCI center. So I call it death by guideline goal. Don't get worn out. If the first 100 great cases you do, you get an email saying, Manesh, you were 94 minutes, you didn't retain the goal. You know, I recognize that that's better than maybe where you were, or where it is exactly where you want to be, or that goal even changed. We used to be great door to balloon, and then it was first contact. And so now there's an extra layer of importance. So I don't think it's always important. They change goals, we change goals because we're striving. But this is from Circulation and Race, North Carolina, say we had 2.4% within goal, 6.7 outside, even after a lot of our great, we thought, improvements. So you can't always get there, but you want to continue to strive. Here's an example. Somebody is at 91 minutes, you know, takes a while to get to first medical contact, and then the system works pretty well. The other thing we realized is as we thought about our care processes, we broke the 90 minutes into 5-minute bundles. We started saying every 5 to 10 minutes, what can we be doing? And can you reduce that 5 to 10 minute bundle? And so, for example, I know in our institution and across the state of North Carolina, on average, interventionists are like, you know, fishermen. They love telling you how fast they open up the artery once the patient got to the cath lab. And so on average, someone says, oh, I opened up in 9 minutes, or I've done it in 11 minutes, or we've had this happen. On average, it's about 22 minutes across the state once they get into the cath lab, because no matter what you do, if you're trying to get EMS to get there fast, they don't always have the pants off. We have now like a new statement, you know, pants off leads on. Like it was, the hardest thing we had was you get there, you're ready to do it, and they're like, oh, we got to get the pants off, and everybody's waiting when we get the pants off. So these are the kinds of things you have to think about. Did you get a tackle box? We put a tackle box in each of these emergency rooms that was called the Race STEMI tackle box that actually had clopidogrel inside of it. Had the leads that are translucent, so when you get to the cath lab and you turn on the x-ray machine, they're not obscuring your image. Those leads can also be used for a balloon pump, so you're not switching leads on the patient. You also have other things that are going to be very helpful for you, but those were the biggest things. We were just getting the right leads at each of the hospitals so that you can do ECGs, you can put the balloon pump on, and they're not radiolucent. I felt like we'd won a war. So those are the types of things you'll have to think about, and we can share some of those things with you as we did that. So care processes associated with quicker ones, as we looked at our data, They're hospital processes, so dedicated STEMI reperfusion team with committed leadership with hospital-specific reperfusion protocol. What does that mean? That means, at minimum, a once-a-month meeting with representatives from the emergency room, the nursing staff, the people who enter your data, the cath lab, the intensive care unit, whoever else is involved in your process, EMS, are in a room with a call-in number, with slides and or data that have been sent at least the day or the night before, so everybody can pull them up when they go through the meeting to say, how are we doing? No process change occurs without some sort of timely feedback. I'll go to that when I get to our actual STEMI cases. But if you tell me 6 months from now I did something wrong, I'll say, well, I don't know. Something. But if you tell me tomorrow morning, hey, that case last night or 2 nights ago, here's what we found, that's very helpful. Same thing for ED processes. So we found that system obtaining that EKG on arrival was a huge barrier for us. And this turned into saying, okay, one, do we have to do it in everyone? And the ED wanted an ED attending to have read it before they activated, which we agreed with. But that then said, so what's the processes? How do you get them checked? Is there a resident, a nurse, somebody who looks at them first? And then how do you get it to an ED attending who then rings the bell? A single call. Each institution has to work towards the single call. So when you trip the button or you say it's time to go, everybody that needs to go needs to know, and it happens, so that our cath lab staff, our CCU, our faculty who's coming in to do the case, if you're at a place where there's nurses and techs that are in different places that have to come in, that single call was a huge, huge step. And each center works different ways of doing it. We're trying to solve that with some technology. EMS processes. So does your EMS have equipment to perform pre-hospital ECGs? We had a very low percentage of that before we started doing that. That's, of course, gained. We have now partners you can also work with, the program for paramedics to recognize STEMI on 12 lead EKGs. So we actually had our fellows and then some of our interventional cardiologists go out across the state, and each hospital system really liked that. And let me tell you, the most empowered group of people once we started this, the drivers of change lived in the EMS and the ED. I had the easiest job. I showed up and opened the artery. It's hard sometimes, but it was awesome. You know, it's fun. You open up an acute MI, it's gratifying. But you know how to do that. You've been trained how to do that. But getting the patient there, when the patient would come, we would say thank you to the EMS, and they would sit in the control room, and they'd love to watch. You mind if we hang out and just watch? We'd be like, absolutely. And they got the feeling of, wow, this is why we brought the patient here, because that is the occluded artery. These guys are working so fast to open up. So what they had to do was they had to get equipment. We had different groups going out and having training courses regionally for them. And then we had this rule, as always, keep the patient on the local stretcher as part of the acute MI. So if you see a STEMI and you put the patient on a stretcher and you go into, you're bringing them to the first hospital and it's going to be a transfer hospital, don't take them off the stretcher. Leave them on the stretcher, have the ECG reviewed, call the number, stabilize the patient, put the stretcher back in the EMS machine, in the wagon, and then keep going. So the vehicle, keeping them on the stretcher. So our rule about keeping them on the stretcher is also why the pants didn't come off, because they didn't do anything, which was right. So we started by saying, keep them on the stretcher. They kept them on the stretcher. They'd rocket them to us. And then when they get there, we go, oh, they didn't get into the gown of the other hospital, which we were used to seeing. But it was a good new problem because we were reducing time to get to our hospital. This one's not so great, but with every iteration from months 1, 2, 3 processes, we were able to reduce time in different places, and I'll go through some of those. So what were the objectives of RACE AMI in North Carolina, and how did we actually come about, and why did we call it RACE? So we wanted to actually first increase the reperfusion rate, not the speed, actually. We thought there were patients, and we all know this, you'd show up and go, this was an acute MI. Something should have happened where this person should have got reperfusion, whether it's a lytic at the outside hospital or something. This was an opportunity. So we said, there got to be some patients that we know aren't getting in. This seems like the biggest, if you're sort of like NNT, how many number of patients I treat to save a life, this seemed like a bigger goal than this one. Even though I'm saying door to balloon, of course, helps patients, the process improves patient care, the first was a bigger goal. And then we started with a pilot in 2003. We did 65 hospitals in 2005 through 7, and then the emergency rooms in 08 and 09 throughout the state. So funding, data collection, feedback, and structure was step 1. These regional PCI centers with primary PCI lytic ineligible patients and rescue protocols were put in place. I'm going to show you those protocols in a second. Then we did hospital by hospital establishment of a STEMI plan. And it was surprising. Once you put people in a room, even, I'll just say not even in our region, you go to CMC Charlotte or you go to these very Presbyterian, very big hospitals, great cardiologists. Once they were in a room, once we all agreed that we're trying to get everybody's arteries open as fast as possible, we came up with overflow, divert pathways. The hospitals can and will work together when it's this type of an effort. EMS established a STEMI plan, and we had, clearly, patients will get activated, and you come in and go, oh, that's reperfusion, that's early repolarization, that's not a STEMI. That's okay. We went through a whole lot of review, training to improve the system. And of course, as you've already heard, if you don't measure it, you can't improve it. And action registries, at least right now, I think the way you get these data easiest. And so another thing that's happening is all of your hospitals are already participating, having someone fill this out. So if they're doing that, let's empower them. Let's figure out ways to do the chart review to get the right data and to give you feedback. And I'll show you how we do it at our institution. So defining roles and empowering healthcare providers. This is the way we thought you could move forward. So this is why we call it RACE. So when we started, we actually had a team building exercise where we went down to Charlotte where they do NASCAR, and they have this thing where the pit crew teaches you how to have team building by saying, okay, they drive in this NASCAR and you're going to change the 4 tires and load it up with gas. And you have your cath lab and your EMS and your sort of Duke team first. And then, of course, you have Rex and Charlotte. So you're all trying to do better, right? So we're going to beat the UNC guys. We're Duke. I mean, how are we going to lose those guys? So then you go in there and you start trying to change the tires and load up the gas, and you realize, this is hard. And you look over there, and you're not supposed to look over there, and then this thing falls down. So the first time we did it was like 14 minutes, you know? And these guys do it in like 17 seconds. So it was definitely like, wow, we got a long ways to go. But by the end of the day, we were doing it like a minute and a half. And what we realized is when they came in and they said, okay, look, you don't ever look at anybody else. You just run out here and put this thing in here. And you just get the ratchet and do the ratchet thing, and then somebody else is going to carry the tire. Tire's too heavy for you two, so you two are going to be the tire carriers. So actually, when we got back to the cath lab, we sort of looked through our team and said, okay, every case, when the STEMI is about to come, before the STEMI comes, we have to call out who's on the monitor, who's scrubbing, who's getting devices. And the person who's getting devices says, anterior, inferior, what do you want? What are you looking for? We have like a little team brief. And then actually we have these cameras for live case and other things. I just turned that on and did a few of those tapes so that we'd take staff and we'd be a little John Madden. We'd be like, over here, like for this 2 minutes, you were daydreaming. What was going on? You were just hanging out next to the gloves. You know, when you're hanging out next to the gloves, you could be getting like some pads and put some pads on because the patient's hypotensive, right? So it was really empowering because the team, even though it's a sort of a team building exercise, RACE came about because we realized everybody has a role. And if you can do your role, you're going to get better with this. So the other thing we developed, which you can actually get on the web, and I'll talk to Chris and stuff, we can help get these out if you guys want. We had an operations manual. So we built this manual that we put into every hospital and every cath lab, every place to say, here's what we're going to do. This is optimal. We all agreed upon after our meetings that this is what we're going to do from EMS, the transfer centers, the cath lab, anything else we could think of we're going to do. And inside the operations manual, the first rule was, we don't want any IV, no IV infusion. Like, there was tremendous amounts of time when the heparin bag was being hung and people were trying to hook it up and put them on a gurney and all this stuff. It was unbelievable. So it was like, if you want to bolus them, that's great, but we don't need a drip of a heparin. Just give them clopidogrel, put them in the truck, and let's keep going. So this whole idea of no IV infusion was transformative. And everybody on the team loved it. From EMS to nursing to the docs, we all loved it. We didn't say, by the way, this got lost sometimes, we didn't say no IV access. We said they need IV access, but we can't have infusions. So everybody got an IV access, everybody got dose of drug, and then they went. So that was first rule for us. Second one was we then said, okay, what are we going to give in a standard format? You can go through the guidelines, you can decide what you want. I know there are new thienopyridines, but every ED in our state still doesn't have all the prasugrel, ticagrelor, all that other stuff. So Duke's own ACS algorithm certainly has ticagrelor as our own choice. But if you come to any place in the North Carolina region where you're going to get a primary PCI, they do this. They give you a bolus of heparin. They give you aspirin. They give you clopidogrel. They can give you paste if they think your pressure's okay, and they can give you a shot of morphine, and that's it. Off you go. Every time, every place. And then we said, okay, if you want to give lytics, here are the doses of these 2 drugs, and then we have another page for those. And then we defined our rescue thing. If you've done this, patient's having pain, call the place and get going. And here's the second page. So we went, if you go to the second page, we have our dosing guidelines for all the things somebody might want to use with dose adjustment for age and weight. This in itself made it much easier because there was always one place everybody was looking for the drugs. We were always saying, we hope that we can be A+, not C-, and go left. And we put North Carolina up here, but I'm not sure North Carolina was up there originally. But you could imagine there were others. But the idea was we're all as a state trying to, I'll talk about appropriate use and a pilot we're trying to do there for that, but all as a state trying to say, can we, as a group, make sure we get patients that have acute MI that first get reperfusion and then second, get as fast as possible. So what did we do? We had some contentious moments. So like next year when you guys come back to this meeting, will you be able to share your hospitals, let's say A through R, and then once the doors are closed, take away the A through R's and say, what can we all figure out for these guys and what are these guys doing better than that? This is a level of stuff we had never thought about, but we had to sit in a room and say, boy, even though I didn't think of it, these guys in Asheville have figured out some stuff that we don't know about and we got to learn from them. So best practices have to be looked at. You have to be mature enough to say, our practice isn't the best practice in the world, and we're all willing to learn from one another. Okay, so we did have data, of course, that we found that clearly with all of this activity, importantly, we were able to drive down door-to-device times, and I think at the end of the day, that was one of our intentional goals. And our reperfusion times, even with lytics and door-in, door-out times came down, and you'll see this, after years of activity, our door-in, door-out time was 97 minutes. So yeah, there was an opportunity. It's not 30, it's 45. I'm not sure we'll ever get to 30, but we'll keep trying. But 45, I think, is a pretty respectable amount. And then door-to-needle for fibrinolysis really got pushed down. But here are the real sort of drivers of change for us. Anytime I speak about this or anyone speaks about this, we had a set of coordinators, really, really passionate patient advocate nurses, nurse clinicians, others throughout all these areas that were at each center saying, in this region, I'm going to look at these 4 hospitals, go talk to them and say, what's going on? And it was point of care. It was like, it's sort of like the Pulp Fiction movie. There's like the wolf. There was a problem, you could call them, and it was a 10-minute drive. They'd be there in 5. You know, like they already tell me the answer. We say, something happened last night on the coast. There was a patient on a ferry arresting. What are we doing about that? And 2 hours later, there'd be a proposal for a plan with the regional doctors. And so that's the kind of stuff that really made it fun and made us figure it out. And so just a little blow up of our state so you guys see sort of what we're thinking about. So blue is primary PCI centers. The yellow ones are the places that agreed to transfer for primary PCI. The red ones said we'll lice, and we preferentially said a lot of the coast we would lice because it was just so hard to get patients back. And then some mixed places, and we're still working on what does mixed mean and how do you have some places that want to do primary PCI during the day and want to lice at night, and we're still dealing with a lot of things everybody deals with. And we're not saying it's bad because there's not enough coverage in some of these places to sort that out. And then as soon as you start showing that you can do those things you are fortunate, and you will too, to have sponsors and partners that want to come and have similar goals as you do. Here are the patients we took care of. So we were able to identify that of our 6,800 patients, half were direct, roughly, or 57%. 43% were transfers. They looked pretty similar, actually, as you think about it. Shock, I'll just tell you this. Before we started RACE, our shock presentation was lower. We had more and more. The faster you start getting to people, the more cardiac arrest and the more shock you're going to see. And so even if the mortality's flat, sometimes I'll argue that it's because you're getting to people that you didn't get used to get to. I'm going to show you one case. I used to start this off with a UPS guy that was actually about 40 minutes from us that I got to see my second or third year out, who had a left main occlusion. Shocky, left main occlusion. We didn't used to see that. Now we have a case series of 6 or 7 that come through, and you figure out what to do, and it's not all great, but these are cases that this type of behavior brings to you, and that's okay. But you have to be ready to understand that there's going to be some of those things coming your way. Here's the other thing I'll just show you. So our strategies, so we with this is a thing now as an interventionist, I think it's great. You know, our systems increase, we do more primary PCI, and we do a little bit less fibrinolysis, and I think that's okay if you can get more primary PCI done. The other thing is, it depends where you are, but for those patients that go to walk-in and direct EMS, we were able to get more people all the way in, and then we were able to get patients from both places that were meeting door to balloon and getting to our place fast. PCI centers, non-PCI centers, this was an interesting patient presentation change. So EMS that used to do a lot going to non-PCI centers, as we worked protocols, we're bypassing them, going to PCI centers. And so PCI center EMS presentation went up, whereas non-PCI center walk-in presentation went up, and they had to deal a little bit more with what to do when somebody walks in with crushing chest pain and then has a new left bundle or anterior STs, et cetera. And then here's our pre-hospital ECG. So in pre-race in 2003, 2004, at best we were 41%. We got partners. We partnered with all of our EMS centers, and now we're up to about 88% in the state doing some sort of pre-hospital ECG, which is, again, another central feature that we can talk about. Does it make a difference on patient outcome? So before phase 1, after phase 2, a little bit of reduction, probably 1%, which I would say is, again, substantial. But I think we're also taking care of a little higher shock group, but that's the mortality data. So here are the top lessons from RACE MI in North Carolina. I'm happy to share. And look, again, as I said, most of this is done by many other people, but I think these are pretty reasonable lessons. It's possible to fundamentally change the way we deliver care on a broad scale via grassroots efforts. This isn't Duke doctors saying this is what we want to do. These are EMS people in each of the hospitals, in each of the emergency rooms saying we want to take better care of our patients. Data drives change. So if you have the data and the data comes back repeatedly, it will drive change. Identify and empower passionate providers. You saw the nurse clinicians I showed you. Systems work best when each person has a well-defined role and a standard protocol. Everybody wants to do something. It's sort of like that pit crew thing. You want to do stuff. You're fired up to get the car done, but if you don't know what you're supposed to do, there's a lot of expended energy. Competition can be managed to benefit patients. This is something we all deal with. Keep it simple and standardized. Keep EMS at the center stage because they're first responders bringing the patients to the patient places where they get taken care of. And so in many ways, they have been the biggest advocates for this whole process for us. We're obviously expanding nationally. Mission Lifeline with everyone is going through this. So you guys are doing it. It sounds like Colorado's doing it. Everyone's doing it, and I think that's a great thing. And these are the things I'll just highlight for you. You guys already do pretty good on age-adjusted mortality from acute MI. We weren't doing as well until we did this, and then, of course, there's the heart attack belt here through the middle of the United States. And then you'll see where there are systems and where there aren't and where places can do better. And hopefully it has the greatest change. You guys obviously have your state up here that you're talking about. And then door-to-balloon times throughout the country with action, 2007, 2011. So transfer is less than 120 nationally, and single center is less than 60, or near 60 now. So here's a case I'll just show you quickly. This is where we're going. 57-year-old gentleman, pretty recently, cardioverted VTVF, inferior STEMI, taken across county line. So that's one thing EMS didn't used to do. We've convinced them. EMS is county organization. In some places, they went across a county line, passed the non-PCI center to us, 32-minute transport time. He was unresponsive, taken to our lab, multiple arrests, had a right coronary that we opened, and then he got cooled with Arctic sun. That's what we use to cool. And then Chris Granger and one of our fellows wrote up the case and actually have a map in the case of how he was brought to us. And here's the right coronary. We put some bare metal stents in him. He had an enlarged RV that wasn't contracting and then got a lot of it back, thankfully, before he went home. Shock presentation home at 8 days. Pretty good for us. Here's email. This isn't that patient, but this I just wanted to show you contemporarily. This is what happens at my hospital and a lot of the hospitals. There's no patient information on here that I can tell. I was just looking through it earlier. But it'll tell it that patient information's up here, then there's an age. This is just from a few days ago. Onset, pressure, nausea. This was where we put our transfer outside hospital information in the email. First medical contact time, ECG if done. When was that done? Was it diagnostic? Which mode of transport? Activation time. So did the EMS then call 115 and activate? Then it goes from the activation to arrival at our hospital. Our attending that was present, fellow, CCU attending, fellow. You don't have to have all that. The ED attending. Here's a big one. If they're transferred from another hospital, we put in a process where every time in the cath lab, we would call back the transferring ED doc and say, I want to make sure you know we saw this patient. Here's what happened. Thanks for getting him here. We opened it up. That was the biggest lesson learning to connecting the dots. And they then would say, oh, that's great. I usually don't hear about it, or that person was in the prior shift. I'll let them know, whatever. And then we would have to document it. One of my metrics were how often did I call back in all of race so that the system would be closed. And then we'd put in any like VF arrest and mid-LED and then times down here. So it's a multifaceted approach. I think post-cardiac arrest is now going to go with cooling, and I think you can imagine that we're getting towards sudden cardiac arrest, and that's our goal in trying to improve how these patients do. So sudden cardiac arrest now has partners across the state, as you guys know, and are across the country. And so I think as you think about your regional STEMI networks, think about sudden cardiac arrest, because centers that are going to be seeing the same patients are going to have to deal with cardiac arrest resuscitation. So I want to thank all of you for listening. Obviously, this was started by a fellow, Matt Lofty, who doesn't do as much anymore, but Chris Granger, James Jollis, our interventional team at our institution, but the 20 other institutions and partners. And if you go back to that Race STEMI publication, every center had 2 people recognize that they chose on that publication for JAMA to say they were the ones in the state of North Carolina. And then, of course, first and foremost, our staff, our EMS, our ED, and then the patients involved. Thank you.